many people misunderstand occupational health as occupational therapy. These two are different. Now, this is entirely a new concept which has surfaced in last few years in the whole world. So, International Labour Organization, WHO, International Commission on Occupational Health, and WONCA, as well as Indian Association of Occupational Health, our focus is now to use and exploit primary health care system so that occupational health service can be delivered as per Alma Ata Convention to everyone who is working in this country. So, Constitution of India promises that states shall make provisions for securing just and humane conditions of work. This provides the basis for provision of basic occupational health service to all the citizens of the country. Now, the short form of basic occupational health services has been internationally accepted as BOHS. So, henceforth, I'll refer to BOHS, okay? So, as Amanda Howe said, let's call for ending inequality and discrimination in health services. I would add one word, occupational health services. So, in first 5 minutes, I'll give you the perspective of occupational health, the mortality and morbidity, and our share of that in the whole world's burden. Workforce distribution. If you see Southeast Asia, we have the maximum number of agriculture workers, we have maximum people employed in industry, we have maximum number in services. But that is not all. We have 1.3 billion people, of which about 63% are employable and able people to work. But the most amazing part is that 92% of people who work in India, they work in unorganized sector. Unorganized sector is a sector which is most neglected sector, not in this country, but all over the world. So, we thought that if as an organization NGO looking after the occupational health as a specialty, what will be our contribution to this country? So we decided to do something very concrete rather than just giving a talk in a conference and going home and forget about it. So we have started a project which says BOHS for informal industry workers through primary care physicians, primary care providers. So as I told you, there is a huge number of employable people in unorganized sector. There are now almost equal number of male and female workers, particularly in rural areas, and 58% of them work in agriculture and fisheries. Our industry, organized industry, is only a small portion. It employs only about 13 million people. There are 200,000 working factories at this moment in India. They only employ 13 million people. So, unorganized sector is the big chunk of employment. Now, most of the time we try to ignore this sector thinking that their contribution to this country is hardly anything. But you are in for a shock because there are 4 important things this unorganized sector does. A, vital role in terms of providing employment. Gentlemen, can you switch off your telephone, sir? It's disturbing other people and me too, okay? So it's it gives opportunity of employment to large number of people, although sadly at a very low wage, contributes to the national product significantly. The NDP contribution of this sector is over 60%. So it's more than what 8% industries contribute. The share of household sector in the total gross domestic saving also is 3/4. So 3/4 of the saving of this country comes from informal sector. And unorganized sector has a very crucial role, as I said, in this country's economy. So how is it that we are still not able to look after them? In the whole world, India has about 17% share of the burden of illnesses and diseases caused by occupations. 3 billion workers in the world, of which 80% work without any access to occupational health services. So we are not alone in this world. Even countries like England, countries like France, they all have this same problem. The coverage is diminishing rather than increasing, and 100 million occupational injuries cause 100,000 deaths globally. This is the WHO figure. So our share is 17 million occupational non-fatal injuries, 45,000 fatal injuries, and out of 11 million cases of occupational diseases in the world, we have 1.9 million cases. So it's a serious problem. But there is also a simple trick available to us, which we are not using till now. It has been studied internationally that if you make primary care physician aware of occupational health problems, make him aware what can happen due to an occupation, most of the time he will be able to handle it if he knows what occupation has caused it. If he also develops an attitude that I want to learn and treat occupational diseases, it's very simple. It's just like practicing your internal medicine. There is nothing magical or nothing miraculous about occupational health. It is simply speaking, you employ your ability to handle epidemiological diseases in a long-term basis. So if you have these two things, a good attitude to ask patient what is your occupation and to learn something about occupations, I think 88% success is guaranteed. But like all countries, our occupational health is ailing. There is no reporting in this country. There is underreporting. Even if there is a fatal injury in the factory, the employer would try to conceal it from the government or factory inspectors. You will be surprised that even Indonesia, which is 1/4 of this country, Sri Lanka, which is a small island, Thailand and Bangladesh, which are all smaller than us, they report more occupational injuries than India. Can you believe that? So it makes impossible for any government to convince or make a policy. And then, of course, there is lack of occupational service, particularly in this sector. So we have to find a solution. Let's see what solution we can find. First thing is that we don't have enough capacity to deal with occupational health diseases and injuries of this country. As of today, we need approximately 8,000 to 10,000 occupational health specialists. As of today, there are only about 3,000 animals like me who have studied occupational health formally. So there is so much of deficit. In today's time, we'll need about 10,000 people, but at the rate of 460 qualified men coming out of medical colleges per year, it will take us 20 years to fill up today's gap. So you can imagine that this is a perpetual deficiency we are going to suffer from. And occupational health, unfortunately, is the least attractive career option. Although there is a lot of money there, but people are not aware of it. So as I told you right in the beginning, all these organizations are seized with this problem that how do we provide occupational health service even in the basic form to informal sector, which forms large workforce of the country. So we also are trying to lend our might to this whole effort. Our biggest resource today is primary healthcare system. First, let us try to take PHCs. There are at least 28,000 PHCs in this country. There are community health centers in this country. So that whole system itself there are total primary care delivery outlets are 171,000 in this country. So we have enough capacity or enough resource to learn occupational health diseases and deliver a service. Then we have ESIS. Now ESIS was basically conceptualized to give some service to the workers of the industrial world. But unfortunately, they have entangled themselves into, with all the apologies to ESIS people, to giving only certificates of illness and certificates of fitness. There are, according to ESIS authorities, they have got occupational health centers, but in those hospitals, there is only one occupational health expert. So there is a mismatch between the capacity and the demand. Then we have family doctors who practice in a private capacity. Allopathic are 1/3. Registered ISM family physicians are also approximately 1/3, and the quacks are 1/3. So this is our capacity. So we have at least 500,000 qualified practitioners of modern medicine available to us. There are also NGOs working in villages in large numbers. We can take help of them. So after solution, let's find out what remedy we can apply to this whole thing. So we started a project which envisages as follows. First, we will have to train the workforce which is available to us but which are not trained in occupational health. So let's train them. But to go to 28,000 PHCs and thousands of doctors, it's not possible for an organization like mine which doesn't have financial resources. So to do this pilot project, what we thought, we'll make a model which will prepare a model in a few states. If the model is successful, we'll look at it after 1 year. If everything is going hunky-dory, we will produce this model in front of government and say that this is the way to go. And we will, of course, volunteer ourselves to be of help to the government of India so that this can spread to all the parts of the country. So the first step was to prepare a training manual, but we don't want to make every village doctor or every primary care physician into an expert occupational health specialist. The reason is that if the largest population of this country is in informal sector, let us identify which are those occupations which are very dangerous to our largest workforce. So what we have done in this manual, we identified 22 informal sector occupations and given everything which can, disease or injury which can be caused by this particular occupation. For example, agriculture. 50% of workers are in agriculture, so you must learn about agriculture. There is farming, there is forestry, there is toddy tapping, there is beedi making, there are scavengers, there are people who work in stone quarries, gate workers and things like this. So we have identified 22 including vegetable vendors on the street. So these 22 occupations, if you learn about them, you will be addressing occupational health problems of 450 million people. And to learn 22 disease entities is not very difficult, because you have studied the whole of medicine by now. So these 22 occupations are to be studied. It's only 4 pages each, and in simple language. And at the end of in the last section of the book, there is clinical perspective of each of them. So you will also get clinical knowledge out of the same book, and you are done. So you become a BOHP, that means Basic Occupational Health Physician, like we used to have a barefoot doctor concept in the past. So you will become a barefoot occupational health physician. That is the whole idea. In stage 2, the manual is already ready and it's gone for printing. It's a 400-page manual, but in a very simple, understandable language. Stage 2, phase-wise implementation of training to PHC doctors. Phase 1, training to be launched in selected 20 PHCs within Maharashtra. Maharashtra has about 200 PHCs. Phase 2, 2000. Phase 2, extension of the project to 4 states, Goa, Gujarat, Karnataka, and Tamil Nadu. Yesterday I met the medical director of Bengal Health Services, and he has promised to include Bengal in this. So that's one more state. And phase 3 will be, we will be going to all these trained people, do the hand-holding for about 6 months, and then evaluate how they are doing in the occupational health service. So, only out-of-the-box thinking can fulfill the dream of basic occupational health services for all. Thank you very much.